public comments, and then at the conclusion, if the committee so desires, you can raise a question with particular individuals, but that'll be in a shorter period of about 5 minutes. So, okay. All right, and Melvin is going to be keeping time for us, so please be mindful. He'll stand up with the card if you don't see it. And we have the names of those who pre-registered to give public comment. And the first person to respond was Carl Schmidt. Mr. Schmidt.
Good afternoon. Is this on?
Yes.
No.
Great. When the strategy was released by President Obama, the AIDS Institute praised him for developing such an ambitious product. We also commented that in order for it to be successful, there must be necessary leadership and resources to achieve its goals. Today, we would like to focus on one population the strategy identifies as the group most affected by HIV and the only group in which the number of new infections is growing, gay and bisexual men. In the strategy, it states, the United States cannot reduce the number of HIV infections nationally without better addressing HIV among gay and bisexual men. And it recommends, given all the starkness and enduring nature of the disparate impact on gay and bisexual men, it is important to significantly reprioritize resources and attention to this community. The severity of HIV among gay men was underscored last week when the CDC released data from a study that found almost 1 in 5 men in 21 major cities are infected with HIV, and nearly half of them didn't know about it. What we need now is an appropriate response by our government at all levels to ensure that acceptable policies are in place. Prevention research is conducted, and the resources are available to decrease HIV infection among gay men of all races and ethnicities. Despite the long history of HIV among gay men, there are still only a handful of behavioral interventions for men who have sex with men. The CDC, by its own admission, as you heard today, has indicated its prevention expenditures do not match the level needed for gay men. A resource allocation model developed by the CDC concludes that if the level of incidence in the U.S. is to decrease, more resources need to be focused on gay men and other MSM. We applaud the White House and the CDC for taking some initial steps to target new resources and programs to gay men and urge your continuation and expansion. In your role as one of the groups charged with reviewing the strategy's implementation, we ask you to make sure the federal government is doing all it can to address HIV in the gay community. The federal implementation plan just mentions a few initial steps. We now look forward to the detailed agency implementation plans and their thoughts on how we can do a better job in addressing HIV among gay and bisexual men. As the strategy states, it will not be successful without doing so. Thank you.
Anna Ford, next speaker.
Good afternoon. My name is Anna Ford. I serve as the director of UCHAPS, the Urban Coalition for HIV/AIDS Prevention Services, the 7 CDC directly funded jurisdictions that shoulder a third of America's HIV burden. First and foremost, I would like to formally express our desire to partner with PACTA and other stakeholders to achieve the critical and far-reaching prevention goals of the National HIV/AIDS Strategy and to help drive its implementation. Scale-up of HIV prevention in urban America is critical to the success of the strategy and also the health of our nation, as 85% of our country's HIV burden is in the 50 metropolitan areas with 500,000 or more residents. We applaud CDC for its recent initiative that targets the 12 metropolitan areas most impacted by HIV, developed in close consultation with UCHAPS. This approach, consistent with the first prevention step of the National HIV/AIDS Strategy's federal implementation plan, needs to be expanded at the CDC and more critically broadened across many federal agencies. While our President has reminded us that we must focus efforts in communities where HIV is most heavily concentrated to achieve our national goals, the allocation of prevention funding does not always adhere to this principle. Our federal and state partners must redesign the geographic distribution of prevention resources and base them on the most recent epidemiological data and sound public health principles. Without significant increases in funding for prevention programs, Revising formulas to match current data will result in drastic shifts in funding, both across states and within. UCHAP strongly believes that resources will have the greatest impact when they follow the epidemic. I'd like to just give one example of funding algorithms not really following the epidemic, and use the example of New York City. New York City accounts for nearly 90% of New York State's HIV and AIDS epidemic, largely driving the federal award to the state of New York. New York State receives $27 million from CDC for prevention programs, and while they fund some community-based organizations in New York City, they don't fund any, or no funding goes to New York City's health department. So when you look at New York City gets $21 million for 109,000 cases, and New York State gets $27 million for 16,000 living AIDS cases. Compare that to a state like Florida that only receives $19 million for 90,000 cases when you look at prevalence. We see this imbalance in other urban jurisdictions, Philadelphia, Chicago, also very notably, and also when you look at all southern states. Every single southern state, when you look at current data, is woefully underfunded for prevention. And so we urge PACHA to support prevention funding algorithms that align with the National HIV and AIDS strategy, hold federal, state, and local governments accountable, and end the common state practice of divesting in America's HIV epicenters in response to increased but still insufficient federal support. We look forward to working in collaboration with PACHA, ONAP, and HHS towards a much improved prevention resource allocation strategy so that we can in fact reduce HIV incidence in America by 25% by 2015. Thank you for your time and attention.
Andrea Weddle.
Good afternoon, and thank you for the opportunity to comment. My name is Andrea Weddle, and I'll be offering comments on behalf of the HIV Medicine Association and the Ryan White Medical Providers Coalition, which is a group of frontline providers that HIVMA sponsors. I missed this morning's session because I was actually at the final workshop that was organized by the Institute of Medicine to specifically look at HIV care system issues as we look to implementing routine HIV screening more widely. And I would urge you to, it was an excellent day and a half where many of the issues that came up during today's access to care presentation, which was also excellent, came up. And so I would hope that in terms of developing a white paper, many of those issues could be considered that will be addressed in their report. Our organizations together, HIVMA and the Ryan White Medical Providers Coalition, developed a set of recommendations for the implementation plan, in particular to strengthen it. And many are similar to the issues raised in Mr. Greenwald's excellent presentation earlier today. Two in particular that I wanted to draw your attention to that our members are deeply concerned about now, but really even more so as we transition to new payers coming into the mix and having a much larger HIV population depending on Medicaid. The first one is to really, for CMS, working with HRSA to develop new creative payment systems for providers that can support the type of really comprehensive coordinated care that is currently largely supported by Ryan White, but so that can be supported under Medicaid, Medicare, and other payers. And we can figure out how to do that. I know New York has some excellent models for looking at the data and developing those systems. The second is, throughout the implementation strategy, there's a lot of discussion about expanding care capacity by urging more providers to do HIV, and which is something we absolutely support because the HIV workforce issue is critical. We're going to expand access to care. But our chief concern is that there was not a lot of talk about really the expertise and experience that is really necessary to deliver high quality care, which has been well documented in a number of studies over the past decade. So we would hope that as you're in your role in monitoring the implementation of the strategy, that you would look to see how we're not only expanding, as more providers are expanding and providing HIV care, but they're also really developing their expertise through more intensive clinical training opportunities and not simply through continuing medical education and those sorts of events. So thank you very much, and thank you for the work you're already doing in moving the strategy and health reform forward. Thanks.
Jenny Collier.
Hi, Thank you. I'm Jenny Collier from the Ryan White Medical Providers Coalition, and Andrea just delivered our joint comments. But thank you again for the opportunity to hear this meeting today. It's been very helpful, and we're pleased to see that we're so much in agreement with the presentation that was just made. Thanks.
Marcia Jones. Marcia Jones. Jennifer Howell. Roberto.
She's coming.
Sorry.
I'm sorry, I was listening today and I redid everything that I had prepared. My name is Jennifer Howell and I'm from Reno, Nevada. I have been involved in HIV work since I was 14. And I stand before you today as a public health professional, but more importantly as a person who's been involved in the HIV community for as long as I can remember, on a very personal level. I would guess, as many of you in this room, I've dedicated my life to making the lives of those infected and affected better so that they may live a life where HIV is more of a chronic disease rather than a pervasive constant influence that is critically acute. And of course, preventing HIV infection so a person and family does not experience all that this disease has to offer. We know that women are particularly susceptible biologically to being infected and having HIV disease progress. Compounding these facts are the caregiving roles, the female condition that women are placed in our society and in our social structures. As noted by the Kaiser Family Foundation, efforts to stem the tide of the U.S. HIV/AIDS epidemic will increasingly depend on how and to what extent its effect on women and girls is addressed. How do we address it then? The tools and systems are in place, but the processes, the motivation, and the specific intention to do so are still in obvious flux. The community and providers are waiting. We are all waiting to see if, at the highest level, there will be a collective sigh of relief because a document, albeit vital, has been completed, or if there will be practical, immediate, accountable, transparent implementation that makes sense, that will work. This is no small feat, neither is the disease that continues to evade us. Dr. Baldessari noted that federal agencies and the programs involved are committed to doing things differently. I've sat here today and thought we are so close and yet so far. How are things going to be different? We have been a community deluged with new starts via new recommendations, new CARE Acts, new guidances. Socially and environmentally, we can have an impact, but all of the resources and bureaucracy need to be streamlined. ASOs need to be empowered to care for their clients more than they respond to data requests and collection. Clients need to trust that they can speak up for their care and not be excluded from any resources or care, and the isolation of entities has to stop. If not, if these walls do not come down, the disease defeats us medically, morally, and socially. I do not find this to be an acceptable option for those that care and keep our society on its feet. That is the role of the bus driver, the accountant, the mother, the sister, the doctor, the nurse, the infected, the affected, the daughter, the woman, the person. Clients or families are ready, service providers are ready. We're all ready for coordinated cooperative agreements. We're committed to change. We're ready for the leadership. We know that, or if you find it difficult to have agencies heads meet and get a plan done by December, know what is going on in Reno and other quasi-urban and rural areas. Reno is not one of the 12 urban areas being researched for prevention due to a higher burden of disease. It is a lower prevalence area with a recipe for a higher burden. Incredibly high chlamydia rates, increasing teen pregnancy and unwanted pregnancies, a higher rate of secondary pregnancies than Las Vegas, being in a state with constant unemployment and foreclosure rates, overrun substance abuse and mental health treatment facilities with incredibly high substance use, high crime rates, transient populations, a 24-hour lifestyle, and pervasive stigma, to name a few of the ingredients. Let us not forget that this is in Nevada, a state that spends the third least amount of money per capita than any states in our union. A woman is navigating all or many of these programs to get basic needs met for those that she's responsible for and then for herself. She is more likely between the ages of 25 to 34, a woman of color, and was infected through heterosexual contact. She's driving around or taking a bus, walking with children to the food pantry, then to the Medicaid office, then to the substance abuse treatment outpatient class, back to the case manager because a form needs to be filled out for housing, to the local housing authority to deliver the paper, applying for jobs so she continued to